You agree?
Okay.
There we go. Again, hello everybody, good afternoon. I'm Dr. Saeed Mokhtari, Assistant Professor of the Department of Pediatric Dentistry in Dental School of Tehran, University of Medical Sciences. We are now here to have another international webinar from Tehran University of Medical Sciences. And we have a guest that I think all of you know him because he is the co-author of one of the most popular textbooks on pediatric dentistry, McDonald's and Average Dentistry for the Child and Adolescents. Hello again, Dr. Dean. You are very welcome.
Good evening, everybody. Are you ready for me to start now?
Let me first introduce you to the participants, if you agree. Okay. Jeffrey Dean is the Ralph E. McDonald Professor of Pediatric Dentistry and a Professor of Orthodontics and Dentofacial Orthopedics at the Indiana University School of Dentistry and Riley Hospital for Children at IU Health in Indianapolis. He received his bachelor's degree from Purdue University and his master's and doctoral degrees in dentistry, as well as his specialty certificates in pediatric dentistry and orthodontics from Indiana University. He has served as a hospital residency program director, chair of the Department of Oral Facial Development, associate dean for faculty affairs, and executive associate dean of the School of Dentistry, as well as chief of staff and senior advisor for the IUPUI chancellor. In addition, he completed a United States State Department Fulbright Scholarship to work with the Royal College of Surgeons in Ireland Faculty of Dentistry when he received an honorary fellowship. Jeff is a board certified.
Saida, I'm so sorry to interrupt. That's too much. That's great right there. Is that okay?
Okay, I will finish it. Jeff is an editor and co-author of the comprehensive textbook on pediatric dentistry, McDonald and Average Dentistry for the Child and Adolescent. And in addition to his full-time academic work, he maintains an extramural pediatric dentistry and orthodontic private practice. Dr. Dean, it's really an honor of us to meet you here, even virtually.
Okay, thank you. You're so kind.
I think we can start. The platform is yours, Doctor.
Okay, you're so sweet to read all that. Thank you so much. And thanks for the invitation to come here. This all started a year and a half ago, I think, with some informal conversations, and took a long time for us to get this all worked out. But so it's so exciting to be here with you all. It'd be so much more fun if we were in person with each other. I would love that.
Thank you very much, Doctor.
Yes, thank you. And thinking about how I think this is about an hour. Is that right, Saida?
Yeah.
We're going to take about 60 minutes. So
yeah.
It's not enough time to really tackle these two topics very deeply. So I just thought I'd try to briefly, in maybe 25 minutes or so, review some of the fun things that are going on in guidelines and research in these two areas, and then just open the floor up for us to have some discussion. So that's the format that I'm looking for. Excuse me. I have this first slide here. Oh, good. My pointer's working. I don't know how many of you maybe have heard of the name Pop Sweet. He is one of it's this gentleman right here. In the early 1900s, he was one of the first advocates for using formicreosol for pulpotomies. And I was lucky enough back in 2019 to give the Pop Sweet, his nickname was Pop, which is an interesting nickname. I'm a grandfather, but my grandkids don't call me Pop. But that was his nickname. His colleagues called him Pop Sweet. And I was lucky enough to be invited to give a talk for a full day on these two topics in San Francisco a couple of years ago. Okay, let's see. My clicker's gone quiet again. All right, then a pop-up telling me the meeting's being recorded. Hang in there, folks. There we go. I put this slide in as a reminder for me to ask a little bit about the makeup of the audience. But we've already talked, Saida and I talked a little bit before we started, so I'm just going to keep going on. She mentioned my private practice, and while I am a full-time academic at Indiana University, I do have a private practice with a couple of partners, and these are my staff. I think that's important because all too often audiences think, oh, you know, this guy, all he does is academic stuff. He doesn't really understand how hard it is to run a private practice. And I really enjoy my private practice, as I'm sure most of you do also. This is a wonderful slide. I cherish this photo with Dr. McDonald seated and Dr. Avery to my left. These, at the time, these were all of Dr. McDonald's textbooks that he had published. And we have done a couple more since then. The textbook has been, we're proud, it's been translated into 8 languages, including this one here that you see. And it made me think that I wanted to let you all know that I'm proud to say that I served with Nasser Paydar, who is the chancellor of our campus here in Indianapolis. Nasser is Iranian. And I served, I initially served as Chancellor Bance's chief of staff, and then Chancellor Paydar came on. This is a little bit old photo. He was the executive vice chancellor before he became chancellor. But there's me down there serving on the same cabinet with him. That was a pleasure to get to do that with him. And we just released the 11th edition of the textbook, which is a great relief. As you can imagine, it's a lot of work to do these textbooks. Okay, so why did I decide to do this format for the lecture? As we all know, we're being inundated constantly with tons of information. It's so hard to keep up with what's going on, not only locally, but regionally and internationally. You know, what's going on around the world. It's just so difficult, and it just seems to get more and more difficult to keep up with the literature. This slide reminds me of my brother. My older brother used to do punch cards on the computer back in the 1970s because he was really interested in computer science back then. And the fact that in the 1980s, I did my master's research project on a floppy disk. I have one of the first computers in our department back in 1980. Of course, now we're using the cloud and all kinds of other things to store our data. But what I'm trying to get at is that human knowledge is doubling exponentially, and it's getting faster and faster and more, as you all know. This is a little bit of an old slide from 2013, but they were predicting back then that the doubling of knowledge, human knowledge, would be every 12 hours. And so if you're feeling like I do, that's a little hard keeping up with everything, I don't blame you. The other concept that I wanted to talk to you about is that not too long ago, when I would give a talk like this, I would complain a little bit about the fact that we just didn't seem to be advancing a whole lot in pediatric dentistry. We were having the same conversations, it seemed, over and over again. About pulp therapy, about restorative materials. It just didn't seem like we were making any progress. But I do feel like the last 10, 15 years, there's been a lot of exciting changes that have occurred. And I don't feel like I'm on that treadmill quite so much. Although I will tell you, I'm glad I'm both a pediatric dentist and an orthodontist. I practice both in my practice and I teach both at the university. But it really does get disheartening seeing preschool children come with significant dental caries day after day after day. That it's very sad, and I can't wait for the day when we figure out how to minimize the problem, that disease. By the way, if you couldn't see, this is a picture of me from 1974. I used to run cross country and track. I suspect most of you are familiar with the Cochrane collaboration, which is a great international network of dedicated people from over 100 countries trying to help healthcare providers with guidelines for care. And so they pick topics in healthcare to have reviews to try and come up with guidelines. And this is one. Now, this is some time ago. If you look down the far left area here, 2003, when this was published, but it was looking at treatment techniques for extensive decay in primary molars. And it was mainly looking at pulp therapy. And this is way too busy for us to read. But mainly they wanted to look at randomized controlled clinical trials. And they, after reviewing the landscape, they came up with 82 studies that they identified, but only 3 that met their requirement for a randomized controlled trial. And I'm proud that one of the 3 is one of my graduate students' work, Brad Fulkerson, here in the middle. And he published this paper, it's been almost 20 years ago, looking at electrosurgical pulpotomies versus former creosote. I don't want to go into the details of it. That's not the importance of it. I just wanted to give you a little bit of background about the Cochrane collaboration. These are a couple of radiographs from Brad's study. And on the left, you see former creosote pulpotomy, and on the right is electrosurgical pulpotomy. And we could talk about that in the question session if you'd like. But the Cochrane collaboration seems to every 6 years or so update the information that they have on these various topics. So this was the latest update that was published in 2018. So between 2003 and 2018, they had done 2 other updates of this. And it just gets better and better. But even every 6 years, it really is not frequently enough because things change quite a bit. I really like this article published in 2012. Is the evidence supporting dental procedures strong? And so these authors looked at Cochrane systematic reviews and came up with this summary table here. And essentially what they found was that in these different specialties in dentistry, they were able to identify these number of reviews by the Cochrane collaboration. And out of those reviews, these are the number of reviews that reported adequate evidence. In other words, something above no evidence or low quality evidence to make recommendations. You can imagine that's not very good. If you have 26 systematic reviews, but only 8 of them had adequate evidence to make any recommendations, that's difficult. So the overall percentage for cariology, restorative dentistry was 31%, and that was the highest one, only 1 out of 3 of the reviews. Now, I understand this was a few years ago, but still, it speaks to the difficulty we're having as a profession internationally trying to come up with guidelines for each other so that we're practicing state-of-the-art dentistry for our patients. Okay, so pulp therapy, let's just touch base on that just briefly. We could go through an entire outline like this in our chapter in the textbook, but we don't have enough time for that. And it'd be repetitive. A lot of the material there, you know. I do think this is an interesting article, and I left this in just for fun in case you hadn't seen it before. It talks about pulp vascularization during tooth development, regeneration, and therapy, as the title implies. But what is interesting about it is the discussion regarding hypoxia, low oxygen levels being the driving force for angiogenesis. And they're looking at various cytokines and how those work. Fascinating material. This was from a few years ago too. Maybe some of you are doing research in this area, I don't know. But this is an exciting area for us, and I look forward to dentistry being able to take advantage of some of this early work and making advances in what we're doing for our patients in terms of pulp therapy. Okay, so there are two systematic reviews that I wanted to highlight just to summarize where I think, as best as I can tell, the state of the art is in primary tooth pulp therapy. Both reviews are by Jim Cole and his colleagues listed here. Extremely well done. Jim Cole has spoken at the International Association of Pediatric Dentistry and in other venues. So if you get a chance to hear him talk about these reviews, I'd recommend it. I think that you would find them interesting. Now, this was the first one he published back in 2017, which I was extremely excited about because my main takeaway from it was indirect pulp therapy is the way to go. And then they just published this last fall, just a little under a year ago, non-vital pulp therapy in primary teeth. And in this article, they've got this graph that I just wanted to briefly go through. It's very confusing. It's very busy, I know. But you might want to access this. You might, if you aren't already using it in your teaching or something like it, I think it's a very valuable tool. What Jim and his authors did here was did an algorithm where they showed the decision-making process in dealing with pulpally involved teeth. So they split it up, and let's go down the left side just briefly and quickly. This is for reversible pulpitis. And so the decision-making tree would be what you've got a vital pulp. The decisions that you might make or the choices you would have would be indirect pulp therapy, direct pulp therapy, or a pulpotomy. And I want to draw your attention before I go on this table to down here, this corner here. Green stands for evidence that was of moderate to high quality. What I'll call yellow is low quality or very low quality evidence. And then the last one is evidence against using the technique. So you can see here that there's relatively good quality evidence for doing indirect pulp treatment and pulpotomies, but not so much for direct pulp caps. So you would want to be judicious in your decision-making process about whether or not you're going to do pulp therapy, direct pulp therapy, I'm sorry. For pulpotomies, they found that doing formicrosol or mineral trioxide aggregate had some of the best evidence, and I don't think that's too surprising. And then down below that, aspartic sulfate, sodium hypochlorite, and lasers. Now, I did electrosurgical pulpotomies. I think electrosurgical and pulpotomy are probably equivalent, so I'd lump the electrosurgical stuff in there. And then calcium hydroxide, there's actually good enough evidence against doing calcium hydroxide pulpotomy. And then, of course, you go into the restorative care. I'm not going to walk through irreversible pulpotomies, irreversible pulpectomies down this section because it's a little too time consuming, and I really want to get to the question and answer session. But you can see they list the evidence for each of these. They even have listed lesion sterilization technique, the Lister technique, which I hope you've heard of, and whether or not there's external and internal root resorption. All right, so let's move on from that and talk a little bit about restorative dentistry, because I want to wrap up and get to our question and answer session. I like to think of pediatric restorative dentistry in terms of prevention, medical management, and surgical management. It helps me in my thinking. It helps me in my discussions with my parents, although I don't give them this outline. What isn't in here, of course, is a behavioral guidance discussion. And we can talk about that in the question and answer session if anybody's interested. To me, prevention is something as simple as, are you brushing your teeth with a fluoridated toothpaste or not? Are you doing fluoride varnish? Are you having doing risk assessment and some sort of regular visits, some assessment by a dental professional? Medical management, I generally think much more along the lines of things like sodium diamine fluoride in particular, but also non-invasive or minimalist approach to caries management. And a good example of that might be the Hall crowns. And then surgical management is where we purposely take the high-speed diamond burr, we cut the tooth down, and then we do the restoration. Again, we could spend a long time going through all the details in a chapter in a textbook about restorative dentistry, but I just wanted to kind of highlight some controversial things to see if it would spur some discussion once I wrap up here in a few minutes. You may have all read Edwina Kidd's article from 2012, where she brought up this controversial topic about should we even be restoring primary teeth? And so the outline of her discussion is here. First, she talks about who are the stakeholders. When we're doing caries treatment, who is impacted and who should have a say in what we're doing? I'm sorry, I did that. We oftentimes don't really think so much about the child, especially if we're dealing with preschoolers. Do they have a say in what they have done? Well, maybe not directly, but possibly indirectly. I guess if they kick, yell, scream, and fight and bite, that's their way of having a say in what you're trying to do for them, right? But not the typical kind of discussion you might have with an 8, 9, 10-year-old on what you're about to do. Certainly, parents are stakeholders in this, and they need to be informed. The dental team has a stake in this too, though. Maybe the best way I think of that is if I have a child that has problems with behavioral control and they kick their feet while I'm trying to do some restorative work and my team's kind of stabilizing the children, but they get kicked in the head because the child's being so active. Well, the dental team has a say in what we're doing and how we're doing it for the kids. And then, of course, who's paying for the treatment? And of course, as you look around the globe, there are very many different types of payment systems. Sometimes it's the parents paying, sometimes there's some sort of third-party payer system, insurance coverage, or there can be governmental coverage of it, society as a whole paying for it. And I'm constantly cognizant of that in my practice. Our public assistance program in the United States is called Medicaid, and about a third of my patients in my prior practice have it. Well, who's paying for that? Well, ultimately, the society is paying for it. And so I struggle to try and keep costs down, not only for the family, but for society as a whole. So when I read this a few years ago, I was excited to see the concept of, well, maybe do no caries removal, open up the lesion to allow cleaning. How about sealing techniques? And you know, we all do lots of pit and fissure sealants, but something along the lines of a Hall crown. Partial caries removal and restoration, the Atraumatic restorative technique. This has several different names: alternative restorative technique, I hope we're all thinking about the same thing, where you just scoop out some of the decay and place some sort of material, maybe a glass ionomer or some other option. And then finally, more typically, the complete caries removal and restoration, or a surgical approach. And then she went on to say, please note that every option involves some non-operative treatment, as discussed in her discussion section in her topic. So she gave a few examples. Here's a couple of lesions, and all she did in this case was open up that lesion. I do not believe silver diamine fluoride was applied here, but that'd be an interesting way to approaching it. And so both these lesions have been opened up with the idea that just by doing that, and the child can get the toothbrush bristles in there to clean it out, maybe that's enough to stop the decay. Interesting idea. I haven't done this very often, but it does go through my mind on occasion. I really enjoy doing Hall crowns, and I hope somebody brings up a discussion about Hall crowns. I'm not going to go into too much detail about that, but I'd enjoy talking about that if you're interested. And then I thought this series of slides was very interesting. It's just showing dealing with a caries lesion, but notice how they remove the biomass with it's a bristle brush, a rotating bristle brush, to remove the biomass in there. Instead of taking a large round burr, which is what I typically do in my practice, would we be smart? Sorry. Would we be smart and better off if we took a bristle brush and maybe have less risk of exposing the pulp, so that we can do indirect pulp treatment? I don't know. I haven't seen too many studies published along those lines. I think it's exciting. And then they went on and placed a glass ionomer restorative material. Maybe you're doing that in your university. I'd love to talk about that if you are. I was pleased to publish this study in the Journal of American Dental Association with Kevin Ludwig. He was a student of mine, and particularly pleased to have these three colleagues. Margarita Fontana in particular is extremely well-known cariologist internationally, well-funded researcher. Kevin went into my practice and gathered data retrospectively. It's just a retrospective study on traditionally prepped teeth and Hall prepped teeth. And the data that he gathered is represented here just quickly. The blue line is the survival estimates for the Hall crown, and the red line is for traditional. And you might wonder, well, why do you have so much more data on the traditional? Well, this was done way back when I was just getting into the Hall crown, and I didn't have as many of them in my practice. It was done, I started doing this Hall crowns, I think about 12, 13, 14 years ago. And this was published in 2014. I'm not going to go through these slides. I guess I should have taken them out. I really wanted to get to this, but that causes a lot of anxiety in some people. In fact, some people get quite upset about it. This article was published, and there are several other opinion pieces. This was just a short communication where this author was slamming some of the work that Nicole Innes did on Hall techniques, saying that the validity of the conclusions were not good, that she really shouldn't have been making those conclusions based on the study. Now, this was back in 2012, and there's been a lot more published about Hall crowns, particularly something just published, I think it was 2019, from work done in the Sudan prospective trial, which was really quite good. But we get upset with each other a lot. New ideas, new data, new research gets debated, and sometimes it's hard for us not to get emotional about these things, and I understand it. When I first saw a presentation given at the International Association for Dental Research on the Hall crowns, I was shocked. I couldn't believe it that somebody was doing that. and now I'm an advocate for it. So there are influences on our adoption of non-surgical caries management techniques. This is a nicely done paper that was just published last month, and looking at some of the factors that dentists talk about, and it was a qualitative study. They looked at worrying about patient safety. Is there enough evidence-based information? Is it part of my philosophy of practice? And I will tell you, for a couple of decades, I feel like I've had a philosophy of trying to practice minimalist intervention. So these things, at least for my own personal practice, seem to fall right into place. And then, of course, keeping parents in mind and as part of the decision-making process, sorry. I love this title that Nicole Innes published in 2016 about hesitation on moving knowledge into action on managing caries. Don't know, can't do, or won't change. You know, there are a lot of stubborn attitudes, and I've had lots of folks argue with me. I've had people come up to me at receptions very angry and upset with me for advocating some of the things that I've just presented to you. Okay, so anyway, quick summary, and I'll wrap up. We've made lots of progress since the 1950s. I don't complain anymore about the progress we're making, although, you know, as science gets better and better, and we're having all this doubling of our human knowledge, I sure hope that we see us figuring out a way to manage whether it's salivary immunoglobulin A or the buffering capacity of our spit or something to help us better manage caries. We have new guidelines to help us in decision making for pulp treatment. I didn't touch base with this in my slides, but I find myself only giving injections when I think the procedure I'm about to perform for a child, if it's a minimal caries, is going to be more uncomfortable than the injection itself. I hope I'm making that clear, and we can talk more about that too. But if I have a small class 1 or 2 lesion on a primary molar, many times I'm just removing the decay and placing the restoration with maybe just nitrous oxide and a little bit of topical anesthetic. We didn't talk about how easy you have access to nitrous oxide, but I do use that quite a bit in my practice. Hall crowns, when appropriate. I do like doing the alternative restorative technique and silver diamine fluoride. I do not do a lot of anterior crowns or zirconia crowns, especially in 5 or 6 year old kids. I will do them occasionally, but that's just my personal preference. I just don't do them very often. And then, of course, SDF to buy time. So with all that, I'm done. I think I did. I went over a little bit. I'm sorry about that, but thanks so much.
Thank you very much, Dr. Dean, for your outstanding presentation that we have ever had in our university. Thank you very much. If you agree, we can go to the next session, questions and answers.
I would love it. Thank you.
Thank you. Dear participants, if you have any question, kindly please write it in the chat box. I will check them. And before that, I can read the written questions that I have received from the colleagues and participants before the webinar. Okay, doctor, you talked about the Hall technique. In the cases which you apply to back-to-back SS crowns with Hall technique, how do you manage interproximal contacts and the difficulty of passing stainless steel crowns through the contacts?
Oh, I love that question. Did you and I talk about that ahead of time? I don't think we did we?
Yeah.
Did we talk about back-to-back Hall crowns before, you and me?
No.
I didn't think we did.
No.
I didn't think we did. This is a hot topic at my university right now. So I'm so excited you asked that question. So if I can, I'll try not to make you dizzy. I'm going to go back to this slide right here. When I started doing Hall crowns, I tried, when you need extra space, I tried putting the elastic separator in, which is what Dr. Hall originally advocated. But in my practice, I'm only in my practice 1 day a week, and I just found the separators had fallen out and the contact closed up. It just wasn't working. So I found myself doing a thin, about a 1 millimeter wide proximal slice if there was a tight contact to allow me to seat the crown. Now that involves, though, some discomfort for the child. Sometimes it doesn't involve any discomfort. Some kids will sit there and I do a quick little slice and they don't have any difficulties at all. But sometimes they do. And again, that's where I'll use topical anesthetic and nitrous oxide. I rarely will do local anesthetic. But that 1 millimeter slice allows me to also be able to do back-to-back Hall crowns. Now, when I have to do back-to-back Hall crowns, I might do 1.5 millimeters. So I remove a little bit of the proximal enamel on one of the teeth that's getting a crown, and then maybe a little bit more on the other one, so that makes it just a hair bit wider. But that's all I do. There's no caries removal. There's no occlusal reduction. And then I deliver my crowns. So every year our department faculty has a retreat, and this topic came up. How are you doing these back-to-back Hall crowns? And I just had a student who did a retrospective analysis of the overhang on the mesial and distal surfaces of crowns, both traditional crowns and Hall crowns, to see if there was more overhang with Hall crowns. And he just submitted the article for publication in the International Journal of Pediatric Dentistry. And it's going through review right now. But anyway, he did not look at back-to-back crowns. I think it would be good to do that. That's the next thing I would like a student to do, is go in my practice and look at back-to-back crowns. But I can tell you on Hall crowns versus the traditional crowns, there was no additional overhang. The data was not statistically different. There's just as much overhang with the traditional prep as there was with the Hall prep, which is what I expected. But until you collect some data, you really don't know. Now I'm interested in going back to my practice and looking at those cases where I did back-to-back crowns and see if the overhang is different there. It could be, but I don't think so.
Thank you very much, Doctor.
Sorry, that was such a long answer.
It was okay. Thank you very much. And the next question is about your approach for immature primary teeth which need pulp treatment. I mean, examine a little child, a very young child, which needs pulp therapy for his or her primary teeth with open apices and thin layer of dentines in his teeth canal. So exactly, especially in the anterior, in the anterior primary teeth.
Anterior primary teeth. Yeah, and these kinds of discussions are always a little bit difficult because what I'm visualizing in my head may be a little bit different than what you're visualizing in your head. So I'll do my best, but stop me if I'm not talking about what you want to talk about. I think maybe the best way to answer it would be, do I do indirect pulp caps in the primary dentition and on anterior teeth, and I do. Do I do direct pulp caps on primary anterior teeth? And I do them, but not very often. And that would be more from me doing a mechanical pulp exposure. which takes me way back to when I first was a dental student and I accidentally exposed the pulp horn. And my mentor came over and I was so sad. I was so mad at myself for doing that. And he said, it's no big deal. Just put some calcium hydroxide on and move on. Do I do pulpectomies on primary anterior teeth? Yes, I do. But it goes back to the comment I made about not doing a whole lot of primary anterior crowns. If I'm doing a pulpectomy on a primary anterior tooth, there's probably enough decay that the tooth also needs an anterior crown. So I don't do that very much. I have an interesting set of slides from an article published that I presented in India a couple of years ago. It was not my article, it was one done by someone else that showed some really nice pulpectomized teeth with zirconia crowns placed on them. Anyway, I wish I had that in my slide deck. We could look at that. So I'm more, in terms of pulpectomies and crowns, I'm probably more likely to counsel the parents about maybe we should just extract the teeth. Does that help?
Yes. Okay, doctor, when we have severely destroyed primary incisors, which we want to apply zirconia crowns, what do you do under the zirconia crowns? Do you have a composite core under it?
Yeah, again, it'd be great to have a picture so that we make sure we're talking about the same thing. I will do resin modified glass ionomer cores occasionally underneath the zirconia crowns. I don't do that. I don't need to do the core buildup very often, but when indicated, if there's enough breakdown of the tooth, I will do it. It leads me to start wondering about, well, what if the entire crown was almost destroyed to the level of the gingival tissue? And then I would start worrying, how well am I going to be able to maintain that crown on the tooth in a preschooler that maybe is putting things in their mouth all the time? We had a Dr. Ali from Egypt come talk to us here in Indiana just before the pandemic arrived. And he was talking about primary anterior crowns, luxury or necessity. And you can imagine he was kind of suggesting that maybe it's more of a luxury. But you know, what do you do? Parents are stakeholders. And if you have parents that say to you, I want the most beautiful crown you can put on that primary tooth, most pediatric dentists will say, well, I'll do my best to try to provide you for that. And the zirconia crowns are wonderful crowns. I love them. I like them a lot.
Thank you very much for your answer. And the next question is about the management of semi-erupted immature permanent teeth, which has histological abnormalities such as dentinogenesis imperfecta or the alternar teeth. You know, in these cases, there are a very thin layer of dentin covering the pulp, and beside the pulp protection, the restoration technique is hard. What do you do then in these cases?
Yeah, and I'm sorry to keep falling back to this. It helps so much if we had a photo that we could talk about, and even that would be difficult. I switched my slides off. Is that okay? So we can see each other better?
Yes.
Yeah. Okay. My personal go-to person is on dentinogenesis imperfecta and dental developmental disorders is a gentleman at the University of North Carolina. His name is Tim Wright. And he is one of the individuals, I just brought up that article that was published last month about getting dentists to adopt non-surgical caries management. He was one of the authors in there. He's a pediatric dentist. And he has a beautifully done web-based site on diagnosing and managing dental developmental disorders. So amelogenesis imperfecta, dentinogenesis imperfecta. So I would use that as your reference if you really wanted to dive deep into it. But having said that, what do I typically do? And I'm typically, for posterior teeth, I'm going to be thinking about doing stainless steel crowns on those teeth, if I understood the question correctly.
Yeah, that's okay. Okay, and the other question is about a challenging, I think a challenging thing in the dentistry here. In our country, most of the anesthesiologists say that if we want to do deep sedation, if we want to have deep sedation in our patients, we have time limitation. And if the child needs the time more than 1 hour for his treatment, general anesthesia is better choice. What's about in your country? Do you have limitation time for deep sedations?
Yes, thank you. That's a fun question because around the world it's different. But I think in the United States and Iran, we practice very similar. When we're doing deep sedation, 45 minutes to an hour is the comfort level with our anesthesiologists. I don't know if you have dental anesthesiologists in Iran, but we do have some in the United States, not a lot. I have a colleague who comes to my office 2 or 3 times a month and does, he calls them, he doesn't use the phrase deep sedation, he calls them intravenous general anesthesia. So the kids are beyond deep sedation. But still, he only wants it to be 45 minutes to an hour. So we can do an awful lot in that period of time. But in some cases, it's just not enough time. And so I go to the operating room probably once a month and do cases there with our residents for the more comprehensive, more difficult teeth. You know, if you're going to have to do pulpectomies and second primary molars, which fortunately, you know, we don't have to do too many times. Just it's very time consuming. It takes a while to do those things. And so going to the operating room is that option when it's that long.
And in those cases, do you use water when you use hand pieces?
Yeah, good question. This is one of those times where do as I say, don't do what I do. So I say you should use air water cooling with your high-speed handpiece. But if you came into my office, you would not see me using water. And so I would humbly say, I'm sorry that that's what I do, but that is what I do.
Okay. And is the number of teeth you should treat important in your case selection?
For deep sedation cases?
Yeah.
So this, I told you about my faculty annual retreat. Every June we have this annual retreat. And they were telling me, a couple of my colleagues were saying, why do you do Hall crowns in the operating room? Because you have all the time you want. There's no, you should be doing a more ideal treatment. And my answer to that is, okay, tell me what is more ideal than the Hall technique. I'm assuming you're saying the traditional preparation is more ideal. And then I said, show me the evidence. I need evidence that the traditional preparation is better than the Hall preparation for placement of a crown. Some of you in the audience may be shaking your head saying, why did she invite this guy to come talk to us? He's terrible that he would say that. But in particular, the study published in 2019 out of the Sudan which was a large randomized controlled prospective clinical trial, showed no difference in the success rate between the two. Okay, so how did I get off on this? I'm sorry. You asked me, do I worry about how many teeth if I'm doing a deep sedation? I do Hall crowns unless proven otherwise. And there are some times when you should not do a Hall crown. If the decay goes too far down the side of the tooth, the primary tooth, I won't list the list. It's too long. Well, it's not that long. Anyway, sometimes you shouldn't do it, but most of the time I'm doing Hall crowns. So I can do, if I have to do all 8 posterior primary molars with crowns, I'm doing the Hall technique. It just does not take very long. In fact, I argued to my colleagues, the ones that were unhappy with me doing Hall crowns in the operating room, my comment was, we're worried about preschool children being overexposed to general anesthesia, because it's a little bit of a controversy, but there's some evidence that younger children have negative consequences of general anesthesia. So if we have to do general anesthesia, we should get in, do what we got to do, and get it done. Do it faster. So why would I not do a crown technique that allows me to go faster? So no, I don't worry too much. Where I get worried is if I find that I have to do anterior pulpectomies and anterior crown or cornea crown, or I have to do posterior pulpectomies, because that really adds to the time, the treatment time.
Thank you very much. Doctor, I love deep sedations. My colleagues know, and so I love your opinions about the deep sedation. Thank you very much.
Well, after what I just said, you may never, I may never get to speak with you and your colleagues again. I hope I didn't make too many people mad.
Thank you very much. And the next question is about fermocorazole. What do you use in your routine pulpotomies? Do you use fermocorazole still?
Ooh, that's a good question. And I thought that question might come up. So this is how I've only been asked that question maybe 3 or 4 times. My preference is electrosurgical pulpotomies. And I did them for a long time, 15 years in my practice. But my electrosurgical unit broke. it broke in my practice. And they're very expensive. It's a very expensive piece of equipment just to do a pulpotomy. I really hardly use it for anything else. I was just using it for pulpotomies. So when it broke, I went back to formicreosol. And that's what I do in my practice. Although I was in the operating room last week, our hospital system no longer allows us to use formicreosol. So it's not in the operating room. We were using ferric sulfate, but the evidence for ferric sulfate kept getting worse, more evidence against it. So now we're using mineral trioxide aggregate, and that's what I used last week. Occasionally I will use biodentine, and I think there's good promise with biodentine, but I don't know why last week I thought I'd use MTA instead of biodentine, but that's the choice I made.
Thank you very much. And do you use banded amalgams?
Amalgams are a great restorative material, and I like amalgams a lot. But my practice has evolved over the years to the point where I'm not doing amalgams very often. In primary teeth, I never do amalgams anymore. If I'm doing a class 1 or class 2 restoration in primary teeth, I'm using resin modified glass ionomer. and I've collected some data out of my practice that looks very good. A graduate student collected that data. We never got it published other than in an abstract at a international association meeting. But I prefer that material. I know a lot of people, if they're not going to use amalgam, that will use composite resin, and that's a nice material too, and there's nothing wrong with that. I just prefer the handling properties of resin modified glass ionomer. And even though the fluoride in the glass ionomer probably doesn't help a lot, I like the fact that glass ionomer has fluoride in it. If I was doing an amalgam, would I do a bonded amalgam? I'm not sure that I would. I think there's arguments for doing it. But as a pediatric dentist, I'm usually thinking, I want to be efficient in my treatment, get in, do what I got to do, and be done. And since I do so few amalgams, I probably would have to revisit the current evidence on bonded amalgams to convince myself I was getting enough improvement in the long-term stability of the amalgam by doing it that way.
Thank you very much. Can I have time to ask more questions?
Yes, I'm okay. I have I blocked a full hour and a half, so I've got another 30 minutes if you want to go that long, but please don't feel that you have to.
Thank you very much, Dr. Dean. Do you use etchant agent when you use resin modified glass ionomers?
The manufacturer, we follow the manufacturer guidelines. So I do I'm not exactly sure how much additional benefit we get from that, but I do. I used to place over my resin modified glass ionomer, I used to place sealants over top of them because that's what I did with resin in case I had some sort of cavo surface margin opening, you know, that would allow bacterial penetration, which is a little more likely to happen in resins, I think, than in glass ionomers. But there is a fairly well-known pediatric dental restorative researcher, Kevin Donnelly, out of University of Texas, San Antonio. And he wrote the chapter, our chapter with me on restorative dentistry in the textbook. And I was talking with him one day and I said, so are you putting sealant over your glass ionomers? And he said, no. And I said, oh, I'm surprised. Why not? And he said, because you don't need to. You don't have to worry about marginal leakage nearly as much with glass ionomers.
That's a great idea. And what's your opinion about using indirect pulp therapy in primary molars? And if you do it in one session, or you prefer 2-session treatment?
Oh, good question. I do not do 2 sessions any longer. I think maybe for students, the first few, maybe 3 or 4 indirect pulp therapy that students do just so they have an idea of what's going on underneath a few weeks after the treatment is probably a good educational event for them. But in my practice, I don't do 2 stages. I do it all at once. Based on Jim Cole's article, the systematic review from 2017 on vital pulp therapy options and which materials to use, they felt like there really wasn't a whole lot of difference in the main primary materials being used for indirect pulp therapy. And in fact, Jim Cole and his wife at the time, Sue was editor of the Journal of Pediatric Dentistry. In fact, they were the ones that got me to publish an opinion piece in the journal, the American Academy of Pediatric Dentistry Journal of Pediatric Dentistry about Hall crowns. When you put a stainless steel crown over top of a large lesion, even if you're doing indirect pulp therapy, where you remove the biomass, you remove some of the affected dentin, if you filled it with some sort of glass ionomer cement and then place the crown, you're essentially doing indirect pulp therapy just by doing that. So how often do I do a traditional indirect pulp therapy on a tooth? It's probably not very often, because most of the time I'm doing a crown on those teeth. And if I'm doing a crown on those teeth, I'm doing the Hall technique. So I'm not removing the biomass. Maybe I'm getting off track. Maybe I'm not answering the question correctly.
Thank you very much. And when you are doing pulpotomy with MTA, what do you do with the setting time needed for MTA setting? I mean, you fill the teeth in that session, or you postpone it to the next session?
No, they're very, off the top of my head, I can't think of any techniques that I do where I, other than orthodontics, where I want to do multiple sessions. So I get in, I place the MTA, I let it set as much as I can, but I'm finishing the restoration before I finish that case. So I'm placing the crown before the child wakes up. I don't think I have enough pulpotomies where I could collect any data on that. I'm not sure I've read any articles. If somebody in the audience has read articles looking at setting time variation in terms of when the restoration is placed, I'd be interested in hearing about it. So if an audience member wants to talk about that, it's okay by me.
Thank you very much. And the next question is about resin infiltration. How much effective is resin infiltration in preventive caries progression comparing to fluoride therapy?
Yeah, I love resin infiltration. In fact, I did that on my son when he was a teenager, and it's holding up quite well. I would tell you, though, that maybe I am lazy. I do not think I'm lazy, but maybe I am. But I don't do a whole lot of resin infiltration. It is very difficult for me to explain to the parents what resin infiltration is. And what I mean by difficult, it's time consuming, because parents aren't aware of it. I can tell them it's sort of like a sealant on the occlusal surface, but we're just placing it interproximally. But it isn't just trying to explain the science and the clinical procedure. There's also the payment in the United States for resin infiltration is different, and it's expensive. It's more like a filling material, and so parents struggle. And maybe I'm doing a bad job explaining to the parents, but they struggle understanding what we're doing and why is it so expensive? Why is it better? Well, you're telling me there's a cavity there, but you're not going to put a filling in. You're going to seal it, and it's going to cost me just as much as a filling. And I have to be careful, because if I take my child to another dentist, or I move and go to another dentist, and they take a radiograph and they cannot see the sealant, and they think it's a cavity, so they're going to go ahead and recommend drilling it out and put a filling in. It's just so confusing for the parents. I tend to not doing it. Maybe that's a bad answer. I feel like I'm disappointing your audience, but
no, not at all.
If I had a parent who came in and said, I read about resin infiltration on cavities in between the teeth, and you said my child has some cavities in between the teeth. Will you please do that? I'd say, yes, great, let's do it. I would love to do it. I think it's a great adjunct to our toolkit for treating children.
Okay, and I think because of the time, I will ask the last question. In some cases which we need to do pulpectomies, the canals will not be dried, and we cannot dry the canals because of the bleeding which continues on and on. What do you do in these cases?
Oh, whoever asked that question, it'd be fun if we were standing in the operating room together, looking at that pulp and talking about all the things to think about in a situation like that. I don't use sodium hypochlorite to clean out my canals, but that would be an option, and maybe that would be helpful in stopping the bleeding. I will occasionally use local anesthetic as an irrigant. So I will place the tip of the needle down inside and gently flush material out. Keep in mind, it's not like I'm doing pulpectomies on posterior teeth every week. I just am not doing them. If I were doing pulpectomies every week, I probably would be a little bit more aggressive. I don't use rotary instruments for doing my pulpectomies because I've never trained myself in how to do that. Although we did have a visiting professor from Mansoura University in Egypt who studied using motorized instrumentation, using modern endodontic tools to do primary molar pulpectomies. A fascinating material. He did micro computer tomography images at our university on the teeth that he was treating that way. It was an exciting thing to see and watch him do. So to get back to the question, if I was getting a significant amount of bleeding out of that tooth, ultimately I'd probably decide to extract it. And if it was a second primary molar and I needed to do it, I'd put in a distal shoe space maintainer. Because I think that's an indication that I worry that that's an indication that you've got infection beyond the canal bad enough that your success rate on the pulpectomy may drop quite a bit. Although, again, if you look at Jim Cole's systematic review from last fall, September 2020, where they looked at non-vital pulpectomies, he said the evidence is pretty high as long as you don't have external or internal root resorption, that the technique works pretty well and it's highly successful. So maybe you just go ahead and do it and keep your fingers crossed that it works well.
Thank you very much, Dr. Dean. I don't want to make you tired because I hope you will have another webinar with us again.
It's delightful. It would be fun to do that. I would love to. I want to, oh, isn't this nice? Thank you.
Dr. Dean, thank you very much for your collaboration in this project. And this is the a certification from Tehran University of Medical Sciences, which is shared on the screen. And I will send it to you via email. Okay. Thanks, everyone. It was my pleasure and it's an honor to be here with you. I thank you very much. It was really our honor for you, and thank you very much for accepting our invitation. Well, I look forward someday with all of us in a room together where we can see each other face to face and ask questions. I can hear their voices, ask questions, and see their faces in the same room. Take care. Yeah. Have a good day, doctor. Thank you. Thank you. Thank you very much, doctor. Dear audience, thank you very much for your participation. We all enjoyed this webinar, and I hope this would not be our last webinar together. Have a good day. Have a good evening. Bye-bye. Bye-bye.